All right, let's jump right in. Today we're talking about the hepatic biloma. It's a subtle but really critical post-procedural complication. So if you're on a surgical or a GI rotation, this is a diagnosis you absolutely have to have on your radar.
So, here's how we're going to break it down. First, we'll define what a biloma actually is and, importantly, how it's different from just free bile. Then, we'll get into the most common causes and who's really at risk. After that, we'll walk step by step through the diagnostic pathway, and we'll wrap it all up with the management strategies and the key things you need to walk away with.
Okay, first things first. What exactly are we looking for? Understanding the definition here is so important because, honestly, a biloma's presentation can be deceptively vague. It's sneaky.
Let's put you right in a classic clinical scenario. You've got a patient, they're a few days out from a lap chole. Now, they're not acutely ill, they're not crashing, but they're just not bouncing back, They're complaining about bloating, some fullness in their upper abdomen, maybe they've lost their appetite. What's running through your head? What's on that differential? Keep that in mind as we get into the formal definition.
So, here it is. A biloma is an abnormal, well-circumscribed collection of bile that's sitting outside the biliary tree. The most important word on this entire slide is circumscribed. The body has walled it off. This isn't just free-floating bile causing chaos in the abdomen. It's a contained leak, and that distinction is absolutely everything.
So what it really all boils down to is the speed of the leak. Think of it like a slow, steady drip versus a burst pipe. A slow ooze of bile. That causes this mild local inflammation. The body has time to react, and it builds a little fibrous wall around it, and voila, you have a biloma. On the other hand, if you get a rapid, high-volume leak, it just floods the peritoneum with bile. That causes coliperitoneum and acute biliary peritonitis. It's the same substance, bile, but two totally different clinical pictures.
Okay, so now that we know what it is, where do these leaks come from? Knowing the common causes is really the first step to having that high index of suspicion in the first place.
The overwhelming majority of the time, biliomas are iatrogenic, which means, they're a complication of something we did. Laparoscopic cholecystectomy is the classic culprit. It's the one everybody thinks of. But as you can see, ERCP, liver procedures like RFA or TACE, and really any kind of liver surgery, or even a simple biopsy, can disrupt that delicate biliary tree and cause a leak.
Now, when we talk about lap choles, the rate of a significant recognized bile duct injury is actually pretty low. It's somewhere between about 0.6 and 1.5%. It's an established risk, right? It's something every patient gets consented for. But that number doesn't really tell the whole story.
Because check this out, studies have shown that up to 44% of patients have a small, often totally asymptomatic bile leak after a lap chole. Now, most of these resolve all on their own, no harm, no foul. But this is exactly why you can't just blow off those vague post-op symptoms. A significant number of your patients are leaking a little bile, and in some of them, it's going to collect and become a real clinical problem.
And just so we're being thorough, while most biliomas are caused by procedures, you can also see them after blunt abdominal trauma. Think car accidents. And in really, really rare cases, the biliary tree can actually rupture spontaneously, usually because it was weakened by something like a stone or a tumor. Okay, so you've got this suspicion. You think you might be dealing with a biloma. How do you prove it? This is where having a systematic approach is key, especially because those initial signs are so often easy to miss.
And I really can't stress this enough, patients with biliomas often don't present with screaming peritonitis. Because that leak is slow and contained, you're looking for much more subtle clues. It's that persistent bloating, that feeling of fullness, or that patient who just isn't recovering the way you'd expect them to.
Your workup here follows a really logical path. It all starts with you, with your clinical suspicion. Now, labs can be surprisingly unhelpful. Sure, inflammatory markers might be a little elevated, but they can also be completely normal in up to 40% of cases. So you're going to move to imaging pretty quickly, usually starting with an ultrasound and then confirming with more advanced scans.
Let's break down the imaging options here. An ultrasound is a fantastic first step. It's quick, easy, and it'll tell you, yep, there's a fluid collection. A CT scan gives you a much better anatomical picture of a well-circumscribed, low-density collection. But here's the catch. Neither of those can tell you for sure that it's bile. It could still be an abscess, a seroma, a hematoma. And that's where MRCP and HIDA scans come in. MRCP is great for defining the fluid and trying to find the source of the leak. But the HIDA scan, that's the gold standard for proving an active bile leak. You literally watch the radiotracer leak out of the biliary tree in real time. If you see that, you've nailed your diagnosis.
So, you've confirmed the diagnosis. Now what?
Let's talk about how we manage these and boil everything down to the most important takeaways for you.
For symptomatic biloma, the mainstay of treatment is percutaneous drainage. As you can see, that's how about 70% of these cases are handled. This is a job for interventional radiology. They'll go in, usually with ultrasound or CT guidance, and place a drain to get all that fluid out. And for most patients, that's all they need. Only a small fraction end up needing more invasive things like endoscopic procedures or even surgery.
Now here's a fantastic clinical pearl to stick in your back pocket. Size matters. If you happen to find a small, asymptomatic collection, less than 4 centimeters, it's totally reasonable to just monitor it, because a lot of those will resolve on their own. But once you get bigger than 4 centimeters, they almost never reabsorb, and if the patient becomes symptomatic, it's going to require an intervention.
So why do we care so much about draining these? Because bile is a fantastic culture medium for bacteria. An untreated biloma is at a really high risk for getting a secondary infection, which leads to an abscess, and then sepsis and septic shock. It can also cause problems just from its size, a mass effect, leading to things like cholestasis or even pancreatitis. This is why getting that diagnosis right and acting on it is so important.
If you remember only one thing from this explainer, let it be this. Any delayed recovery after a liver or gallbladder surgery is a possible bile leak until you prove that it's not. Trust your clinical suspicion when a patient just isn't bouncing back the way they should.
The bottom line is this: bilomas don't shout, they whisper. They show up as that annoying bloating, that loss of appetite, that vague failure to thrive after a procedure. Your challenge is to listen for that whisper and act on it. So the real question is, will you spot the signs in time?